Good morning. My name is Kevin Kirkpatrick from the Avery Professional Group. I am joined today by Dr. Kristen Woods, who is the president of Orcinus Health Solutions. Dr. Woods and I have known each other for a while, and today's conversation, just to talk a bit about her background as a physician, as well as her transition into leadership, and potentially give people an idea, if they're a physician and interested in leadership, how they too can make that transition. So good morning, Dr. Woods.
Good morning, Kevin. Thanks for having me on your show. I appreciate that.
No problem. No problem. Do you mind if I refer to you as Kristen going forward?
Oh, yes, please do.
Nice.
I should have said that right away.
Yeah. Well, I mean, I want to be professional. That's my goal this morning, right? So we'll see. So so I have connections on both sides of the border in Canada and the U.S. So, you've got a unique experience where you've worked in the U.S. system and understand the Canadian system as well. And I think let's start is let's talk about how you became a doctor.
Yeah, absolutely. I wanted to be a doctor since I was a very young girl. Probably solidified that decision around ninth grade, but was very interested in how the human body worked from a very young age. My mom was a stay-at-home mom until my sisters and I were all in school full time. And then she went to night school to become a nurse. So in her journey, that really fueled my interest in learning about the sciences and the human body. So I was on a straightaway path through my, undergraduate years at university and then straight to med school, and thought I'm going to be a family physician, and that's what I'm going to do forever and ever, and that's what I'm going to retire from. So I made a pretty much a straight line path through my educational years to get there. And then I practiced for 14 years as a family physician. I delivered babies, practiced in my hometown community, and really, really did enjoy it. However, after a point, I started to become burned out myself as the administrative burden began to grow, and electronic medical records began to enter our workspace. So I took on a leadership role to help build care teams that could support the patient. And I led the initiative to become patient-centered medical homes in our community and in our employed medical group. And that work really fueled in me a desire to become an active leader in healthcare so that I could be part of transformation and change that I saw as necessary to support the physicians and staff and nurses, but also to support the patient journey and the patient experience, which was also suffering, in my opinion, because of the whole, because of all the challenges that we see in the delivery of healthcare today.
Excellent. What was your first? You just mentioned obviously taking on the administration of that group. What was your first leadership role be after that?
So after that, I went to get my master's in medical management from Carnegie Mellon, and there wasn't a position within the health system I was working in the leadership space for me. So I left and went to Blue Cross Blue Shield of Michigan, which is the largest commercial payer in Michigan. And I jokingly say, I went into that pretty blind. I didn't know the difference between a PPO and an HMO on the insurance side. And as a physician, I didn't care. I just wanted to take care of patients. But I had a quick education in how the payer side works. And what I learned during the about 18 months I was with Blue Cross is there are a lot of good people on both sides, the payer side and the clinical side, trying to create transformation and change. Yet we often pit each other against, or we often feel pitted against each other between the clinicians and the payers. And so it was a very eye-opening experience for me, and I learned a ton. And then I was brought back, or wooed back to the medical group that I had left and practiced in, and I was asked to help lead that medical group and then bring a couple medical groups together to form one large medical group under Trinity Health.
Nice, nice. When you talk about a medical group, is that what does that? Because we have in Ontario, let's say we have these family health organizations that are groups of physicians and stuff like that. What do you deem a medical group within the context of your experience?
Yes, and so in the United States, medicine is a lot more corporatized than we see in Canada, and it's in pockets. But in Michigan, upwards of 70% of physicians are in an employed model, especially in the primary care side. So the medical group was owned under Trinity Health, which is a national health system. And our medical group consisted of about 800 physicians, physician assistants, and nurse practitioners of various specialties. So we had primary care, cardiology, cardiovascular surgery, neurosurgery, et cetera. We also had 3 residencies within the medical group, and then all the offices and locations. So the hospitalist group also was part of our medical group, and they covered 3 community hospitals. So all told, I think we had 100 sites where we had professionals working.
Nice. Did you? So this is one thing that I'm always curious about, is because within Canada, each province has a bit of a different model, right? Like some place like PEI and Saskatchewan have employed physicians. Ontario has capitation, which is loosely employed because you're paid based on the size of your roster, but a lot of it is still fee for service, right? And how did, as a physician and as someone who would have recruited physicians in your leadership roles, how did you find the notion of of employed physicians? How did that affect the culture of the physicians?
It's a double-edged sword in a lot of ways. In any employed situation, there's the dance between administration and the front line. And physicians are, highly intelligent, highly motivated individuals that are often very mission-centered and focused on the patient. And then some are interested in the business aspect and some are not.
Mm-hmm.
But it created, there are a lot of articles and such written about when a physician goes from an independently owned practice into an employed model, the drop in productivity that happens. And because in the US, most payment models are still highly fee-for-service, especially in the ambulatory space, the productivity is important. You still have to keep the lights on. But sometimes when physicians would leave from owning their own practice and go into an employment model, they would sort of divorce themselves from the importance of the productivity and the understanding of the overhead costs of keeping a practice open.
Right.
So there's a constant challenge between creating a salary compensation model that incentivized and encouraged and valued physicians versus a purely productivity-based compensation model that just increased burnout and churn. Yeah. So those issues came to head quite often in the employed model. Physicians value autonomy, and we would talk a lot about what does autonomy mean, because the other thing with corporatized medical groups is the adherence to regulatory requirements is much more strict because you're much more likely to be audited if you're part of a large system than a
Right.
small 1 or 2 person practice. So we had stricter quality standards and protocols that physicians didn't always appreciate.
Right.
So there was a lot of work to create standards of care, best practices, and workflows that were data-driven, evidence-informed, so we could get buy-in from the physicians and deliver higher quality without removing autonomy from physicians and the in that art side of practicing medicine.
Well, and it's funny, and I belong to a lot of social media groups that are physician related and healthcare related in general, right? And it's that the second things don't work, everybody automatically wants to blame administration, right? And like it's a hard line to walk because I've worked in large hospitals where I think they may have had a lot of non-clinical people supporting them that maybe they didn't necessarily need. But I've also worked in organizations where they were as lean corporately as they could be because they valued driving as much of the expenses. But as we look to manage and control a system, and specifically in Canada where it's a rationing based system because we have a finite budget, how do we manage ensuring that we can report and ensuring that we can manage the system without removing, or the perception that we're removing funds from the care providers?
Yeah, that's such a challenging area. The high level answer is that we absolutely need physicians' voices at the forefront of this, physicians and nurses, frankly,
Mm-hmm.
the frontline healthcare workers who understand the challenges and complexities out there, having them come to the table and help with these solutions. But from a political and funding strategy, I think going into those global funding envelopes where there is an appropriately sized amount of dollars to care for the population, and then encouraging clinically integrated networks or networks of teams to work together from the ambulatory to the hospital side to the social services side to keep people well and healthy. I think I don't say this loosely because it's much more complicated than just talking about, just create a global funding envelope. But I think, we're seeing examples of this. Jewish General in Montreal has done an amazing job creating that integrated network where they actually have a command center that pulls leaders from all aspects of the community services, healthcare services, and hospital services to collectively problem solve on a day-to-day basis.
Mm-hmm.
I think the Medicare Advantage in the US is another good example of using that global funding envelope, on a per person basis that's risk adjusted to allow care teams to implement the right type of care to deliver the best outcomes for patients. But when we're funding at a bed level or a program level or a disease level, it puts too many constraints on doing the right thing because you have too much money in one space and not enough in another if you really want to look at the continuum of a patient's care journey.
Yeah. I used to manage the recruiting team at Humber River Hospital in North York, and one of the we actually had a GE implemented command center, and
Yes.
it was like an air traffic controller environment, right? And there were staff that were clinical staff nurses, and their job was to to look at patients across different regions, look at risk factors so they could try and get in before an adverse effect. And the hospital itself seems to be performing well financially and clinically because they are identifying utilization, right? They can see when a bed on a acute care floor is empty and cleaned, and be able to move somebody out of a merge to that bed. And there's just so much data, and then propensity for falls and at risk for different things. And it's when I worked there, I looked at it and I honestly thought that every hospital should have one, right?
Yes.
Tampa General has the same thing. They actually looked at how Humber had done it and implemented it in Tampa, Florida. So it's it's an interesting, and I think that we have to look at implementing technology that enables the front line as opposed to technology that we feel tracks the front line. And it's interesting because as somebody who is perceived as knowing a lot of physicians, I get all kinds of tech companies and service providers that reach out to me because they want me to help them get in front of physicians, right? And the problem I have is that often the solution is not to a problem the clinicians have, right? It's a perceived administrative issue, and you're then saying, okay, well, we need the physicians to implement this software, press these 5 buttons, so we can tell how many times there's been a diabetes check, because we want to know how much money the province is using and spending on diabetes, right? And it's like, well, that's adding, it's not subtracting. And if you follow my social media, this is something I say on social media on a regular basis. Until we look at the job and the role of a physician and a role of a nurse too, until we look at how they move through their day and improve things for them, we are literally just layering other things on top of an existing system that is already overburdened, right?
Oh, I think you hit the nail on the head, and there are so many points that you made in there. But the first is, we're not going to solve it for them. That's where we have to have the frontline physicians and nurses in the leadership team helping to solve the problem collectively.
Mm-hmm.
And the other thing that you said is the bringing solutions forward that aren't really solving the root of the problem. We need to really understand the problem and what we're trying to solve before we just throw in technology on top of technology. And there is a lot of opportunity to remove cost from the system simply by going upstream and preventing hospitalizations and excessive care that can be prevented. But we can't do that if we keep hospitals and the health team separate. They have to look at themselves as a continuum in that patient journey. And, Canada is so lucky in some ways because there is rich data to be found. It's just, are we using it optimally? And what does that look like?
Yeah, and it's interesting because I don't want to say how long, because I'm obviously 25, but in the 20 years that I've been in recruiting in healthcare, I've worked directly for 3 hospitals, and I've probably got 15 to 20 clients that are hospitals. And the prevailing thing that I've seen is that nurses and physicians will not stop and work to rules, so to speak, right? Like they just keep taking on. And I think the problem is that we've gotten to a point where we've almost taken that for granted. And I think we need to flip the coin over and say, okay, well, how do we ensure that, this nurse can live the life they want and provide the care they want? And obviously, money doesn't grow on trees, and we can't just spend willy-nilly. But when you look at the nations that spend a lot of money per capita, there's a reality of spending it properly as opposed to just spending it anyways, right? And we often see this notion of, oh, we'll just pay everybody more, right? But it's easier to directly align. If you look at physicians doing locums and nurses doing temporary agency work, they're doing that because they want to manage their schedule. right?
Absolutely.
They're doing it because they don't want to be tied to a specific spot and deal with what comes from that. So, what we're seeing is these trends of, I'm going to go work for an agency because A, I'll make more money, which is relevant, but B, I'm going to control my schedule.
Yep.
Right. So I'm going to work 7 on, 7 off, let's say, because I'll go to North York General, or I'm going to work, 3 days in North York General, 5 days at Humber, and whatever that's going to look like. Right. And I constantly tell hospitals that build your own recruiting firm, right?
Mm-hmm.
Build your own recruiting firm, and, and instead of trying to get 100 nurses and control the schedule for 100 nurses, get 200 nurses and let them control the schedule. Right. And
Yes.
what happens is you might see the hours worked per nurse go up because they're going to work when they want to work. And, maybe sick time and stuff like that goes down because, they're off when they need to be off. And, and like I know certain health entities, predominantly Northern Ontario and rural environments where, they survive on physician locums because the reality is nobody's able to relocate to a community full time for many reasons, spousal employment, access to cultural supports, whatever it might be. So they look at that, right? But what's happening is that because the nurse and the physicians hold the power, they've decided to put us on notice and change the way they're working. Whereas the best organizations are going to be the ones that say, okay, well, this is what they want. How am I going to facilitate that? And and go from there, right? And I look at PEI. They hired family physicians, but didn't give them a roster.
Oh, interesting.
Yeah, they're basically essentially a locum pool. So if I'm a doctor and I want to take a week off to do CME, one of these doctors that's already been hired takes
Mm-hmm.
over my office for the week, right? Because they've got employed physicians and they give them vacation. Well, what good is vacation if you can't take it? Because
Exactly.
there's nobody to see your patients, right? The same thing with locums. People are doing locums because they don't want to settle and then not be able to go off on mat leave, not be able to vacation because they don't have anybody to cover their patients, right? So
Right.
That team-based approach, I think, needs to happen and needs to include all of those other people, right? So we've been chatting a while, and my problem is we could probably chat for a couple of days. But
Oh,
how would you suggest a physician that's currently in a clinical role? How would you suggest they transition, and what do you suggest they do if they want to move into a leadership role?
it's a great question. And there's the, historical path was that it was the older physicians that are getting close to retirement and slowing down their clinical practice, and they grandfathered into leadership roles. But I think we're seeing a big change in that today. And more and more leadership roles for physicians are requiring a master's degree in business or healthcare administration or public health. So the one path is to get more education. But the second path, what's helpful about that is it's didactic and comfortable for physicians to go through that path. But it doesn't always lead to changed behaviors. And I think that having an executive coach is also a strong value add. And so the benefit of an executive coach is that it starts to embed behaviors into the didactic and clinical learning that you get if you do another advanced degree from an administrative standpoint. And um, we think about athletes, for example, that have coaches throughout their entire career because there's always something to work on. That's where an executive coach can really help physicians to make that transition and speak the administrative language that we're not taught in medical school, and learn how to be leaders of teams and people, because physicians are thrown into leadership roles without formal leadership training frequently. And there are a lot of physicians that are introverts. So learning how to channel that energy into a positive way to connect with people without completely draining your own energy if that's not your comfortable spot. Those are just some benefits that can that occur with having a professional coach.
Yeah. It's funny that you say being grandfathered in, because the first hospital that I worked for, that, all of our medical directors and chief of the different programs were essentially, whoever was willing to be voluntold, right?
Yeah.
And I do a good bit of executive physician recruiting now, and there's a bit of a different lens to it. I see more physicians wanting to move into that space, usually part-time, because they still want to do the clinical. And to be honest with you, in Canada, a lot of the compensation for administrative roles is not great. So it's really, you're not doing it for the money from that standpoint, right? So you've got to balance that out by still doing clinical work. So you're not, and a lot of hospitals don't need a full-time person. So unless you get to the larger, 600, 700 bed hospitals and stuff like that. But the ability and the culture and the ability to make change and the ability to have an impact seems to be a really big prevailing notion, right? So it's funny because I see some clients where it takes longer to fill their opportunity, and it's strictly because they don't have the most desirable culture, or sometimes it's they don't have the perceived desirable culture, and you've got to work with them to explain and do that. And it's it comes back to what I said before, right? The organizations that focus on the role of the clinician and takes care of their people and retains their people, they will recruit the best, right? Like it's a chicken and an egg scenario, right? And I work with organizations where I'm like, no, let's look at your committee structure. Let's look at, how you communicate with the physicians, and let's look at those different aspects so that you can build that culture. And, one of my favorite CEOs that I ever worked with, it was little things like he was constantly visible, right? He was going to make the decisions he needed to make because that's what he was mandated to do. But he was going to go sit in the cafeteria at lunch and talk to the nurses and the techs and and he was going to go to physician committee meetings and stuff like that, and have those discussions and before a decision was made. Sometimes it wasn't the popular decision, but that's the reality of being a leader, is that you have to make the best decisions, but I think you make the decision based on input from others, right?
Yes, and I want to add to that, because the glue in that is to help others see themselves in the vision. So number one, there has to be a clear vision, it has to be simple and clear, and helping others see themselves in that vision is a critical role of leadership. And learning to do that is it's a skill set. The other thing that you mentioned, I know we're getting low on time, but I want to add is, you said, physicians, sometimes we take advantage of our frontline physicians and nurses because they're always going to do what's right by the patient. And, they can't just walk away from that. We often as physicians, we bring our hearts forward and, a lot of emotion around patient care, but we have to balance that with the ability to speak in terms of the administration and what's good for the whole. And then getting to points where we're not negotiating against each other, but we're negotiating together to say, how do we create a win for the organization, for the workers, and for the patients? And having that aligned goal is really important. So clarity of vision, and then seeing yourself in that vision.
Well, and I think the breakdown that I've seen as we've tried to implement change was often a lack of communication, right? Because you send a memo or you do something and you expect that they'll read it and go along with it. Whereas they used to make fun of me because I was constantly roaming the hospital, but that's how I met. I had meetings with people, right?
Mm-hmm.
I would go to the hospitalist lounge and meet a hospitalist and talk to them about what was going on and what I was trying to do. I'd go to the surgeon's lounge and talk to them and see. And it was often that influence that helped me get things done, right? So we're at a half an hour, which is when people's attention span starts to wean, I think. But what I want to talk about now in closing is kind of, Orcinus Health Solutions. What services are you providing, and and what is the goal and the value that you want to add to your clients?
Yeah. Orcinus Health Solutions was founded by my husband and partner in business, Paul Woods. And we started out as a healthcare consulting company. We're interested in helping people that want to solve the really complex challenges in healthcare today. And then when I left my last corporate role, I brought in the executive coaching piece. So executive coaching for physicians or healthcare leaders looking to do change management, transformation, and build strong, trusted cultures. And I also do training. I'm certified in assessments like DISC and Hogan, but I'm also certified to deliver Trust Edge workshops and navigational conversation workshops, which is about creating a coaching mindset among the leadership team. Instead of that problem-solving mindset, it's really a coaching mindset. So you bring all the strength of your entire team together and really optimize the talent.
Excellent. Now, and I think it should be said that you work with clients in Canada and the U.S., correct?
Yep, that's exactly right. Continuing to learn from everybody in Canada. There are a lot more similarities fundamentally than there are differences, and it's between the U.S. and Canada. But we're all trying to fight the same challenges. How do we create enough resources to bring good quality healthcare to everybody at an affordable price?
Yeah, it's interesting. I think the fun thing is, and traditional recruitment firms would say, focus on Canada or focus on the US. And I struggle because I find that I like doing both because, there's so many similarities, but there's so many uniqueness as well, right? And there's things that can be learned from each other. And I remember recruiting a family physician out of Buffalo and bringing him to Canada, and his customer service and the way he treated his patients was really innovative, right? Like he walked his patients out the door, right? Like it was very different, and it was because he had to win patients, in the U.S. He wasn't, it wasn't de facto, here's your roster and they're not going anywhere else, right? So it was interesting from that standpoint. So I think there's a lot of different things that we can do well and learn from each other. And I do, I do think that there's probably things that we can teach the American organizations as well, right? So it's interesting. Absolutely. Well, listen, I appreciate you taking the time. I'm assuming you're on LinkedIn. People can find you on LinkedIn if they want to reach out.
Yep, under Kristen Wood. It's pretty easy to find on LinkedIn. Nice. And our website, if you Google Orcinus Health Solutions, you'll come up with our website.
Awesome. Well, listen, I appreciate you taking the time to talk to me today. I look forward to working with you on projects in the future, and thank you for sharing your knowledge.
Likewise. Thanks for having me, Kevin. It's always a pleasure talking with you.
Sounds good. Have a great day.
All right. You too.
Take care.
Bye-bye.